Bismillahirrahmanirrahim. Can everyone hear my voice? Assalamualaikum warahmatullahi wabarakatuh, and a very good morning Abid to the speaker and all the participants. Before we begin our session, let us start with the recitation of Kitab Al-Fatiha. Dear all participants, please Google form for the star point via the link provided in the chat box. Without further ado, I would like to invite Sister Amni from Ishkat to present her case. Please welcome Sister Amni.
Hello. Assalamualaikum.
Yes.
Okay. Assalamualaikum. My name is Wan Nadira from Mishkat Third Year. Today I'll be presenting a case write-up regarding cerebrovascular accident taken from one of our seniors. So we start with the chief complaint. Encik Shaharil, a 66 years old Malay man with underlying diabetes, hypertension and coronary heart disease was admitted to IIUM Medical Center due to right-sided weakness 1 day prior to admission. For the HOPI, he was well until 1 day prior to the admission when he developed sudden onset right-sided weakness when he was walking to the kitchen. He claimed that he cannot move his fingers, unable to grab things using his right hand, and even cannot lift the arm. He also had light right lower limb weakness, which requiring him to sit at that time. He had difficulty to walk and ambulate. His wife also noticed facial asymmetry as right side of his head face was drooped and had slurred speech as he cannot talk properly and had unclear sentences. He also had hoarseness of voice, had difficulty to swallow food and also complained of reduced appetite. Otherwise, he denied any headache, syncope, drooling of saliva, uprolling of eye, bite tongue, flexion of arm, jerky movement or abnormal posture. He denied any numbness or tingling in the peripheries, no fever, nausea, vomiting, coughing or runny nose. No urinary symptoms like urgency, frequency, dysuria or hematuria. No chest pain, dyspnea, palpitation or profuse sweating. No neck stiffness, photophobia or double vision. He denied any giddiness, lightheadedness, confusion or loss of consciousness. Upon further questioning, he claimed history of similar presentation 4 months ago. However, the symptoms appeared for a day only and resolved completely. He denied urinary and fecal incontinence. There is no trauma to the head or fall before and after the body weakness. In view of his current illness, he was brought by his family to emergency department IMC for further management. For the systemic review, all were normal and unremarkable. And then for past medical history, he has hypertension and hyperlipidemia for 20 years with complaint of frequent headache. He claimed that the blood pressure range about 140 to 150 over 80 to 90. He has undergone coronary artery bypass surgery for his ischemic heart disease 10 years ago at IJN. The surgery was uneventful. He has followed up at IJN every 6 monthly. Meanwhile, he has been diagnosed of having diabetes 8 years ago during follow-up. Currently, he claimed that the sugar control is good and he denied any hypo or hyperglycemic symptoms. He denied any blurry of vision, hematuria, frequent skin infection, altered consciousness and peripheral numbness. He has followed up at KK Kurnia 3 monthly for his hypertension, hyperlipidemia and diabetes. Otherwise, he denied any history of blood transfusion. For drug history, currently he is on tablet perindopril 4 mg OD, tablet gliclazide 60 mg OD, and tablet atorvastatin 20 mg OD. However, he occasionally misses the medications. He has no drug allergy or food allergy or taking any traditional medications. For family history, he is the fourth out of 10 siblings. He has strong family history of hypertension, diabetes mellitus, cerebrovascular diseases, cardiovascular diseases, sorry, and his mother has cerebrovascular accident. Otherwise, all his family children are healthy. For social history, he is a pensioner with monthly income of 1,500 ringgit. He lived with his wife and two children in a double-story house. His wife is a full-time housewife. He was an ex-smoker with 82 pack years. He denied any history of illicit drug alcohol intake, denied having any history of sexual promiscuity. The nearest klinik kesihatan is Klinik Kesihatan Kurnia, which only takes about 5 minutes travel. For the physical examination, on general examination, he was alert and oriented to time, place, and person. He was lying comfortably in prop up 45-degree position with no sign in pain. There was facial asymmetry evidenced by loss of right nasolabial fold without loss of wrinkles. There was no abnormal posture noted generally. There was no scleral jaundice, no conjunctival pallor with no cyanosis. There was a branula attached at his left antecubital area with infusion of normal saline 0.9%. He was on catheter for bladder drainage connected to urine bag with straw-colored urine 150 milliliter. The hydrogen status was fair and the capillary refill time was less than 2 seconds. There were two vertical scars over medial sides of both lower limbs with 23 cm and 35 cm length respectively. They were well healed with no erythema or discharge seen. No ankle edema was noted. And then for the vital signs, his blood pressure is 136 over 74. And then his pulse rate is 62 beats per minute with regular rhythm and good volume. His respiratory rate is normal with the evidence of 18 breath per minute and temperature was 37 degrees Celsius. His SpO2 was 96%. For cardiovascular examination on inspection, there was a midline sternotomy scar about 15 cm length with keloid. It was well healed and no discharge seen. However, no visible pulsation or pericardial bulge were seen, no visible jugular venous pressure seen. On palpation, apex beat was felt at 5th intercostal space at mid-clavicular line. It was normal in character and volume with regular rhythm. All peripheral pulse were felt and bilaterally equal with regular rhythm and good volume. No trills at valves region and no parasternal heave were detected. Auscultation revealed normal heart sound with S1 and S2 with no murmur, no additional sound and no pericardial friction. For the neurological examination, the higher mental function was normal with GCS score of 15. No abnormality was noted on cranial nerve examination. The upper and lower limbs were normal in temperature. There was no muscle wasting, fasciculation, paucity of movement, or no abnormal movement or posture noticed. The positive findings were confined to right side of body. For right upper limb, it was hypertonia and the power were reduced at score of 4. However, the reflex was normal. For right lower limb, there was also hypertonia, reduced power with score of 3, normal reflex with positive Babinski sign. Otherwise, the sensation and the proprioception were intact. There was no gait abnormality or cerebral signs. For the abdominal examination and respiratory examination, both were normal and are remarkable. Case summary. Mr. Shahari, a 66 years old man with underlying comorbidities post CABG and diabetes mellitus, presented with right-sided weakness for 1 day duration associated with facial asymmetry, slurred speech and difficulty in swallowing. He has history of similar symptom 4 months ago. On examination, there was right-sided hemiparesis evidenced by hypertonia, reduced power over right upper and lower limbs with positive Babinski sign. So we proceed with the investigation or
Kejap before
okay.
kita proceed for the investigation semua tu, untuk part history dengan examination tu, okay, it was good. Cuma nak tambah sikit, masa history part tu, like I would like to know further lah, kalau patient tu kan dia develop sudden weakness kan masa tengah bawa dapur thing. What was the time frame dia start develop onset tu and then dia presented dekat ED masa tu? Because you want to know kan, kalau patient presented within 4.5 hours then patient indicated untuk thrombolytic therapy. So macam you mentioned dia just for 1 day duration. So I would like to know lah the time frame tu from the onset until patient presented dekat ED, berapa lama the time frame. Lepas tu untuk yang PE tu, sebab this is a neuro case kan, so kalau after general the general inspection semua tu, vital sign, and then you start with neurological examination first, lepas tu baru go into cardiovascular. Dia je kot. I think otherwise macam okay je. Okay, dia cukup proceed.
So we proceed with the investigations. The first one, the patient undergone full blood count. This patient has high total white blood cell and this suggestive of infection. High neutrophils may suggest of bacterial infection. And then for renal profile, patient has increase in urea, hypokalemia and reduced chloride. For urine UFME, normal results. Liver profile, there are rise in total bilirubin with high direct bilirubin. Total protein and globulin were increased. And then for coagulation profile, it was normal. Fasting plasma glucose, also normal. HbA1c was done, but the result is not here. It said here that is pending. And then for the lipid profile, also normal. ECG also normal. And then for chest X-ray, the result shows cardiomegaly. For the CT brain, there was an ill-defined hypodense area at left corona radiata till centrum semiovale. A few fairly well-defined hypodense foci at left lentiform nucleus. No acute intracranial hemorrhage, bilateral, and there was bilateral basal ganglia calcification. And then the USG carotid Doppler also done, but the result was not mentioned here. And then this patient was finally diagnosed with left cerebrovascular accident with right-sided hemiparesis secondary to left corona radiata infarction.
Oh, tadi kita tak discuss apa you punya professional and then you punya differential. Tak kita go into that first.
Okay. Provisional diagnosis is right-sided hemiparesis secondary to left ischemic stroke. Do I need to mention the factor suggesting and the factor again? Okay. And then the differential diagnosis. Differential diagnosis is right-sided hemiparesis secondary to left hemorrhagic stroke. And then also right-sided hemiparesis secondary to transient ischemic attack. And then right-sided hemiparesis secondary to left cerebral abscess. Also, the last suggested differential diagnosis is right-sided hemiparesis secondary to diabetic neuropathy.
Okay. Okay. Usually kalau from my experience lah, kalau discuss dengan doktor, dia tak kasi kita letak differential ischemic stroke, hemorrhagic stroke, TIA. Basically, it just sebab kalau patient presented very early, we cannot differentiate pun kalau patient tu TIA ke ischemic stroke, stroke ke in general. So just cakap as one diagnosis je. right-sided hemiparesis secondary to left-sided cerebrovascular accident. And then yang lain tu macam you can boleh cakap other causes are like metabolic causes like hypoglycemia, since patient ada diabetes, and then electrolyte imbalance. Contoh kalau itulah tak payah itu ikut nanti lah. So metabolic causes like hypoglycemia or electrolyte imbalance, and then infections causes, since patient boleh juga cakap lah infection causes like you cakap tadi brain abscess, boleh juga macam encephalitis, tuberculoma, and then space occupying lesions which is structural intracranial lesions lah, macam brain tumor tadi you ada rule out juga sebenarnya kan. Apa lagi cukup yang important that you should put in the differential lah. Okay.
We proceed with management.
Kita habis investigation kan? Okay lah. Proceed dengan management.
Mr. Shaharil, a 66 years old Malay man, was brought to IMC due to right-sided weakness for 1 day duration. In emergency department, he was kept nail by mouth and put in prop up position to prevent risk of aspiration. Then he was given oxygen via nasoprom 3 liter per minute. Intravenous infusion of normal saline 2 liter over 24 hours was made and continued in ward as maintenance. Blood was taken for investigation. He was on hourly vital sign monitoring. He was planned for urgent CT brain. In the medical ward, he was given oral aspirin 150 mg OD for 1 week course, subcutaneous, and then subcutaneous ranitidine 50 mg injection TDS for 5 days, and oral gliclazide 60 mg OD for 1 week. Stroke registry was done. Blood pressure and dextrose monitoring for 6 hourly. He was encouraged for early mobilization and positioning to prevent bed sore. He was seen by speech therapy for swallowing test and it was positive result. Stroke education was done with patient and his wife regarding his management and compliance to treatment plans. The patient was discharged after 3 days of admission and his condition was stable. He was planned for USG carotid Doppler and to attend speech therapy as outpatient. He then was scheduled to come again to MOPD clinic, medical outpatient department clinic, after 1 week after the ultrasound for further management. He was discharged with tablet aspirin 150 mg OD, tablet perindopril 4 mg OD, and tablet atorvastatin 20 mg OD, and also tablet gliclazide 60 mg OD, all for 1 month course before follow-up. That's all.
Okay. So macam you punya presentation tu, management tu more like macam case summary punya ni lah kan, long case you punya case discussion punya template kan. Tapi kalau in exam semua tu kena discuss in a general way lah. Okay. So tak apalah, I made a slide untuk management for ischemic stroke. Kita continue kat situ je lah boleh? Okay. Mana? Sekejap ni. Tak ada. Tak boleh lah buka entire screen. Window. Lama. Okay. Sekejap eh. Okay. Boleh nampak tak slide? Yeah. Okay. So macam tadi tu Sister Amni dia present based on macam case summary punya ni lah kan. So kalau so for my slides ni, I would like to present on the management of ischemic stroke ni based on how you should present untuk macam BST ke ataupun exam lah, basically bila kita tak tahu kan what is patient's punya status semua tu. So what is our plan according to CPG punya guideline lah. So so this is based solely on our latest CPG lah, which is the 3rd edition Ischemic Stroke Guideline CPG. And most of it tu macam cover juga, tapi cuma I would like to improve on the way of the flow, how it nak present the investigations dengan the treatment outline lah. Okay. So first, kalau kita cakap pasal management tu, we have to know lah that management it comprises of 2 things. First is the investigations and then the treatment outline lah. So untuk investigations, we know kan before we want to proceed with the investigations, we need to know what are differential diagnosis yang kita nak rule out. So investigation tu is not just to confirm our diagnosis, but as well as kita nak rule out our differential. So these are differential diagnosis yang list out in the CPG. So usually kalau discussion, from my experience lah, kalau discussion dengan doktor semua, the most important is, you know lah, our provisional is cerebrovascular accident, which is a vascular causes. Then our differential first is metabolic causes, such as, again, hypoglycemia or electrolyte imbalance, such as hyponatremia or even hyperuremia. And then structural intracranial lesions ataupun space occupying lesions that include either hematoma, brain tumor ataupun any AV malformations. And then infectious causes like encephalitis, meningoencephalitis, also brain abscess and tuberculoma. And others are macam head injury. And all the other differential ni you can put lah kalau it fits your patient punya clinical picture, but put it on the lower down in the list lah. Okay. Okay. And then for investigations pula, macam tadi Sister Amni tu dia arrange ataupun dia list out the investigations tu like from the most simple to more complicated lah. So start with blood investigations and then further on pergi imaging kan. Tapi untuk stroke, I would recommend that kita start with investigations to confirm diagnosis dulu. Sebab patient datang ischemic stroke kat ED is a very emergency punya cases lah kan. So dia macam MI jugalah kalau patient datang with chest pain and all tu macam we want to confirm the diagnosis first and then baru kita proceed with other investigations like baru nak send blood investigation ke apa ke. So sama juga. So usually kalau investigation punya part, the way you present, you boleh cakap lah the first in terms of investigation, first I would like to confirm the diagnosis first by sending patient for urgent CT brain to look to differentiate whether patient have ischemic stroke or hemorrhagic stroke. So in ischemic stroke, I would expect patient to have hypodense lesion lah on CT punya result. While if patient has hemorrhagic stroke, I would expect to see hyperdense lesion. Other than that, CT brain, I would like to also rule out my differential lah, which is the space occupying lesions. Any brain tumor ke, any brain abscess lah, basically all the space occupying lesions juga. And then baru you proceed with other investigations to assess patient's risk factors for for cerebrovascular accident and also to exclude my differential. So first, full blood count, I would like to look for macam polycythemia and then since patient ada diabetes, I would like to send investigation to assess for patient's diabetic control like dextrose peak and then random blood sugar and also HbA1c. Macam tadi investigation yang Sister ni present tu, patient cakap kita hantar fasting blood glucose kan. So usually on presentation patient usually tak fasting lah. So dia tak boleh nak hantar fasting. Usually fasting tu we plan for another day. So tomorrow we send for fasting. So kalau patient presented now, during presentation usually patient tak puasa, so we send for random blood sugar first and then HbA1c. And then I would like to also send for lipid profile to assess for patients ada hypercholesterolemia. And then renal profile, I would like to send for to assess for electrolyte imbalance, to rule out for electrolyte imbalance such as hyponatremia and also any hyperuremia. Sometimes they might as well hantar serum calcium lah to look for hypercalcemia as one of the cause. And then I would like to also send for coagulation profile. First, to rule out bleeding tendency in patient lah that might put patient at risk for hemorrhagic stroke. And another reason is because as a baseline, so a patient might be indicated for intravenous thrombolytic therapy kan. So this is act as a baseline for the patient. And then I would like to do ECG as well to look for any evidence of arrhythmia such as atrial fibrillations lah, one of the most common arrhythmia kan. And I would like to also look for any signs of old infarcts in the ECG that can predispose patients to have arrhythmia as well. And then in terms of imaging, I would like to send for chest x-ray because first I would like to look at the lung field for any evidence of aspiration pneumonia as a complication of ischemic stroke, since patient tadi pun dia ada like difficulty in swallowing kan, so patient might like choke ke apa, so that might predispose to aspiration pneumonia. And also I would like to look at the heart punya at the heart to look for any signs of heart failure. So signs of heart failure tu further lah kalau doktor tanya, one of the famous questions juga lah, what are the signs of heart failure you can see on chest x-ray. So you have to elaborate lah the A, B, C, D, E tu kan. Okay. And then I would like to do echocardiography juga as well to look at if there is any evidence of vegetations or thrombus that can embolize to the brain. And then carotid duplex ultrasound I would like to do to assess for any carotid aneurysm, also any stenosis. For other investigations that we can do, it's not priority lah, but sometimes doktor nak juga dengar, which is 72 hours Holter monitoring. So this one is to catch any paroxysmal atrial fibrillation. Okay. So this is the investigations listed in the CPG lah, basically the summary. You can like go through later lah. Okay. So dah summarize. And then for management pula, untuk management outline for ischemic stroke, dia macam actually senang lah. Dia punya management tu simple. Cuma what make it difficult and complicated is because dia ada banyak sangat benda. So one of the key point untuk cover everything is you kena classify accordingly lah. So and one of the way doktor suka bila kita present on management is we start by saying so our management for ischemic stroke should include multidisciplinary approach, and it can be divided into acute general management, reperfusion therapy, and also the secondary prevention. So in terms of acute general management, first, if patient presented unstable, then I would like to first resuscitate the patient with the ABCD approach tu lah kan, ABCD approach. But if patients presented stable, then I would like to optimize patient's condition lah by ensuring patient has clear airway and good oxygenation. The SpO2 target is above 95%. So we only give supplemental oxygen if the SpO2 drops below 95%. In terms of blood pressure control, so during initial presentation of patient, we would allow patient to have the blood pressure to be on the higher side lah, usually at 160 to 180 systolic ataupun the diastolic 90 to 100. Because if we lower down the BP at the initial presentation, it can worsen the cerebral hypoperfusion. Okay, so we only treat the blood pressure if it exceeds a systolic more than 220 and diastolic 120 millimeter mercury. And another indication for us to lower down the BP is when a patient is indicated for thrombolytic therapy. Then we need to bring the blood pressure down below 185 macam tu. And then the treatment tu kalau BP is too high, then we can give infusions of IV labetalol lah. And then in terms of glucose control, if patients have hyperglycemia, then we need to treat the hyperglycemia with a target of blood glucose level is 6 to 10 millimole per liter. Okay, and then I would like to also manage the complications such as if patient develop aspiration pneumonia and also UTI, then I would like to start patients on antibiotic treatment. And if patients develop elevated intracranial pressure, then I would like to manage as well lah. So usually kalau elevated intracranial pressure, we would put patients on prop up position 30 degree, start patient on IV mannitol, also kalau hyperventilate as well lah. Okay. Then in terms of nutrition juga, I would like to do swallowing test. If patient fail the swallowing test, I would insert the nasogastric tube and then refer patient for dietitian for appropriate nutritional advice. And then I would like to also encourage early mobilizations and refer to physiotherapy for rehabilitations. And again, since patient develop speech juga, I would like to refer patients for speech therapy as well. And then for DVT prophylaxis pula, this one is only applicable if patient is immobile lah. If patient's still able to ambulate semua tu, then we just encourage early mobilizations lah. So in immobile patients yang bedridden semua, the DVT prophylaxis recommended in the guideline is by giving aspirin and also intermittent pneumatic compression. Okay. So again, this is the summary based on the guideline, CPG. Dah covered. Okay. So in terms of reperfusion therapy, we have two available methods lah. First is intravenous thrombolytic therapy, which is the RTPA, the recombinant tissue plasminogen activator, and so another one is endovascular thrombectomy. Okay, so the intravenous thrombolytic therapy ni, we have eligibility criteria based on the guideline. It says bila patient has clinical diagnosis of acute ischemic stroke, patient presented within 4.5 hours of the onset, the non-contrasted CT scan or MRI to already exclude patient has hemorrhage, and there is no contraindications. So kalau in exam ke apa, kalau you don't know how to put this into words semua tu, one way of doing it, kalau after you finish on the acute general management tu, you can just sambung je. Cakap, once the diagnosis of ischemic stroke is established, I would like to assess patients eligibility for thrombolytic therapy. So which is patient presented within 4.5 hours of onset, patient have indication and patient does not have contraindications to thrombolytic therapy. So kalau usually takat tu je lah you mention, kadang kalau doktor tanya further then you can elaborate further. Like some of doktor nak dengar juga kalau doktor tanya what are indication yang you tahu, you boleh jawab based on the NIHSS scoring, which is, so this NIHSS scoring ni, function dia is first to assess severity, assess indication for thrombolytic therapy, also predict clinical outcomes. It has 11 parameters, but usually doktor tak pernah tanya pun. Even in clinical pun, usually they just ada macam this online calculator, so they just fill in whatever patient have, and it will come out with a score. So the score tu macam ni lah, like 0 patient tak ada stroke symptoms, 1 to 4 patient have minor stroke, 5 to 15 moderate, 16 to 20 moderate to severe, and 21 to 42 severe stroke. So for patients to be indicated for thrombolytic therapy, patient need to have a significant neurological deficit lah. So which is according to NIHSS scoring tu 6 and above. So kalau patient ada score 6 and above, then patient is indicated for thrombolytic therapy. And other indication lah, macam patient presented within 4.5 hours semua tu. And for contraindications pula, we have absolute contraindications and relative contraindications. And this one pun kalau masa discussion dengan doctors pun tak adalah dia nak tahu in details pun, but it's good to know lah. Usually kalau the absolute contraindications tu, bila BP is too high, which is more than 185 systolic or more than 110 diastolic, patient ada hypoglycemia less than 2.7, patient ada risk of bleeding. Either patient is currently on anticoagulant treatment within 24 hours, ataupun patient punya coag profile is prolonged, ataupun dia punya platelet count is less than 100. And then this relative contraindications pun macam ada banyak lah juga. It's good to know lah. But basically macam all things yang boleh put patients at risk for bleeding lah basically. And then if patient is indicated ataupun eligible to receive the thrombolytic therapy, then what are options we can give is by giving infusions of alteplase lah. And then the regimen semua ni tak payah tahu sangat pun okay je lah. Doktor tak pernah tanya juga lah what the dose, how you give, how much semua tu tak adalah bagi tanya sangat pun. And you just need to know that the options is we give alteplase and the alternative is by giving tianectaplase. Okay. And then another methods of reperfusion tu is endovascular thrombectomy. So this one approach is a bit more invasive lah compared to intravenous thrombolytic therapy kan. So and from experience tu macam we never actually discuss this pun dengan lecturer, tak pernah touch on this pun. But it's good to know lah that we have these options if patient presented in the first 24 hours of the stroke onset and patient has evidence of large vessel occlusions, then patient is recommended to receive the endovascular thrombectomy. If patient presented within 4.5 hours of stroke and kita ada juga evidence of large vessel occlusions, then what we can do is we can do drip and ship. So this is here we do both lah, intravascular thrombolysis and then send patient for endovascular thrombectomy. Okay. Okay, and then in terms of secondary prevention, it can be divided into pharmacological and non-pharmacological. Yang surgical ni it just another options lah. So available especially kalau the problem tu originate from the carotid punya problem. So you can do carotid endarterectomy so to remove the carotid atherosclerosis kan, and also carotid angioplasty and stenting. Tapi it's just one of the options lah, macam tak penting sangat kot. Okay. So usually yang penting is the pharmacological and non-pharmacological punya method. So so for pharmacological prevention, first is on antiplatelet therapy, either single antiplatelet therapy or double antiplatelet therapy. You can do this. Okay. So options of antiplatelet therapy that we can give is aspirin, clopidogrel, ticlopidine. Ni yang macam common lah, yang bawah ni macam less common juga. And the new guidelines, it says now there is role of double therapy. Kalau previously, so this new guideline ni just baru release je lah masa I was in final year last year tu, we still refer to the second edition. So based on this latest CPG, there is role of giving double antiplatelet therapy, which is a combination of clopidogrel dengan aspirin. And this is recommended with patient presented with minor ischemic stroke and also high risk DIA for durations for 21 days. So minor ischemic stroke ni again it refer dekat NIHSS score tadi lah. Kalau patient ada less than 5 score, then patient ada minor ischemic stroke. So those are patients yang indicated for double therapy lah. Otherwise, still stick to the single antiplatelet therapy, either with aspirin only atau clopidogrel only macam tu. Second is antihypertensive treatment by giving ACE inhibitor. So they find out that ACE inhibitor tu is one of the macam beneficial lah to as a secondary prevention for stroke, and also lipid lowering agent. Lipid lowering agent by giving less statin therapy. So it should be considered in all patients with LDL target kita is less than 1.8. So basically this first three prevention ni, antiplatelet, antihypertensive and lipid lowering agents is what we give to all patients yang ada yang develop ischemic stroke. Regardless patient tu ada hypertension ke tak, we still give antihypertension. Regardless patient ada dyslipidemia ke tak, kita still bagi this statin therapy. Okay. And then for diabetic control pula in diabetic patients lah. So dia tak specify specifically. So we just for diabetic patient, then we need to ensure that patient have a good diabetic control. And then for non-pharmacological, if patient is smoking, then we need to advise patient to stop smoking. Okay. Basically yang tadi setakat tu je lah. So for management kita ada acute general management, reperfusion therapy dengan secondary prevention. And then this one I just letak additional je lah because macam discussion dengan doktor, usually one of the famous discussion is regarding prevention of stroke in AFib patient. So kat sini lah famous soalan doktor tanya. So how do you decide nak start up in atrial fibrillation patient? So kat situ comes into picture pasal Chart-VAS punya discussion. So we know kan Chart-VAS punya score kalau refer to the old guideline, dia cakap kalau score is 0 then we don't give anything. Score less than 2 we start patient on aspirin, 2 and above we start patient on oral anticoagulant regardless of the gender. But now the new recommendation says to start patients on oral anticoagulant for male patient the score is 2 and above, but for female is 3 and above. Okay. So this one is a new recommendation lah, I would like to note it macam tu. Not much je lah kot. So as a secondary preventions, again kalau DOAC is more preferred lah over vitamin K antagonist, which is the warfarin and aspirin. Tak banyak kot, itu je kot so far I would like to share. Ada soalan apa-apa tak? Try go too fast ke apa? Any questions? Sekejap salah, I pakai dua device, sorry lah. Kat mana nak tengok komen? Lupa dah. Kat mana komen? Sini Okay. Any tips for good history taking in presentation for year 3? Korang sebenarnya exam ni modified long case ke ataupun dia traditional long case yang ambil risiko panjang tu? Hello?
For clinical just OSCE.
Oh, OSCE. Maksudnya?
Ya betul. Ada station history taking physical.
Berapa lama nak history taking tu?
Maksudnya 10 minutes je.
Oh, so dia basically sama lah macam modified long case gitu orang. Okay. Personally kan, for me, I memang buat template soalan apa nak tanya. So that 10 minutes tu memang pang-pang-pang je lah. Dah tahu dah nak tanya apa. So macam, you need to know lah what common cases. Kiranya macam stroke memang common lah sebab patient memang boleh, yang banyak patient and boleh masuk your end of block exam, boleh masuk yang punya final pro. Kalau macam mana cakap, so memang I buat template sendiri. Kiranya kalau you need to know lah, macam kalau history, the presentation of history tu, it comprises mainly the first one tu kena tahu the chief complaint and the elaborations of the chief complaint. Kiranya kan macam tadi lah, macam sister to present, patient complain of right-sided body weakness. And then you elaborate further lah, patient suddenly develop apa-apa, then it associated with apa-apa-apa. And then otherwise rule out your differential juga. And also rule out apa yang tak ada lah dekat patient tu. Macam contoh macam tadi patient presented with right-sided body weakness. Itu sama je lah. It was associated with, dia tanyalah macam unable to stand ke apa, tak boleh nak hold things ke, associated with facial weakness, drooling ke, slurred speech. Otherwise it was not associated with macam vomiting ke, severe headache ke, patient denied any fever. Macam you follow macam tu lah. Macam cara you cara I ambil history, dia follow cara I nak present. Kira kalau I present first apa dia simptom-simptom, kena tanya macam tu lah. So sebab masa modified long case kan doctors dengar kan kita ambil history kan. So it should be organised lah. First you tanya what are symptoms yang dia ada. Lepas tu apa yang tak ada. And then you want to rule out differential. Lepas tu furthermore macam apa risk factor yang patient ada. Like you suspect patient ada ischemic stroke. Lepas tu apa risk factor yang patient ada. Like patient ada DM, control ke tak, hypertension, hyperlipidemia, any previous stroke ke tak, any family history ke tak. Dia macam follow lah. So, macam the way I make it supaya tak thought block masa exam. So usually masa exam tu kita macam blank kan. So I always have a template lah how what to ask macam tu. Any more? Ada lagi ke soalan before we stop? How to differentiate TIA and stroke? Okay. It's back to the definition lah. So kalau stroke is the sudden loss of neurological function and it lasts more than 24 hours. Tapi TIA, it's also sudden loss of neurological function but resolved within 24 hours. Itu je lah. Kalau masa patient presented early kan, macam katalah very early within like few hours macam tu, tak boleh nak differentiate lagi. Especially kalau the stroke tu macam very minor stroke lah, macam setakat body weakness je ke, macam weakness sikit-sikit je. Kalau macam major stroke, like kalau patient tu develop teruk lah, like apa macam paci semua tu kan. So macam that is less likely for the patient to be TIA lah. Tapi we still cannot decide masa tu sebab still the time frame tu it doesn't fit lah to say that. Tapi still based on the definition, TIA is it is a temporary loss of neurological function that will resolve within 24 hours. Macam tu. Itu je lah. Okay. And then in terms of yang stroke pula, macam kan we have two strokes kan, hemorrhagic strokes dengan ischemic stroke. So kalau patient presented dekat initial presentation tu, sebelum patient buat CT brain, we cannot decide whether patient tu ada hemorrhagic stroke ataupun ischemic stroke. Tak boleh nak cakap sebab it is still based on our CT brain punya result. Tapi of course lah, clinically macam apa benda yang boleh suggest more to hemorrhagic stroke is bila patient tu ada underlying hypertension, especially kalau very uncontrolled hypertension, and then patient ada complaint of history of having severe headache. So that's one of the signs to say patient maybe boleh develop hemorrhagic stroke. And usually kalau hemorrhagic stroke punya patient, they would have a very severe punya stroke lah. Patient would presented macam ada loss of consciousness, tak sedar, very unstable, BP macam sky high, semua tu lah, like kadang pupillary reflex apa semua tu macam teruk lah usually clinically. Tapi still for the sake of our level tu, bila patient presented dekat ED ke apa, and nampak clinically patient ada stroke punya symptoms, still we cannot decide whether patient ada ischemic stroke ataupun hemorrhagic stroke until we send patient for CT brain. Only after that baru boleh sebut lah. That's why tadi masa you discuss on your punya provisional diagnosis and the differential diagnosis tu, tak boleh nak put as a separate entity lah. You tak boleh nak put TIA satu, stroke ischemic stroke satu, hemorrhagic stroke satu. Jadi doktor tak terima lah. Okay. Location of the stroke from history taking and examination. Macam internal capsule ke midbrain ke. Okay. Location. Okay, kalau the brain tu, macam ni nak cakap. The brain tu, location tu macam boleh jadi which part of the brain ataupun which artery yang involved. Kalau in terms of artery yang involved, especially kalau major artery lah, kan kita ada 3 major artery lah, mesti kiranya anterior circulations, kita ada anterior cerebral dengan middle cerebral artery kan, posterior kita ada posterior cerebral lah kan basically. So kalau contoh it affects the anterior circulation, so clinically patient punya, kan kalau kita tengok anatomy of the brain kan, the homunculus kan, so if it affects the anterior cerebral artery, patient would have dia punya lower limb punya weakness is more severe than the upper limb punya weakness. Macam tadi tak ingat case tadi mana lagi teruk tu. Tapi itulah basically kalau benda tu, kalau patient ada lower limb weakness is more severe than the upper limb weakness, then it can suggest that patient might dia punya infarct tu involve dia punya anterior cerebral punya circulation. Tapi still again lah, tak tahulah selagi kita tak buat CT brain kan, but from the history tu it can suggest lah. And then if it affects macam patient ada cerebellar punya signs kan, macam apa, cerebellar sign ni pun important juga, doktor suka tanya juga, it's like give me 10 cerebellar signs that you know. So if patient develop any cerebellar signs tu, it suggests more suggestive that patient develop posterior punya circulation infarct. Kalau in terms of location, contoh macam brain parts, let's say kalau it affects, kita tahu kan like different parts of the brain tu ada different functions. Let's say the frontal lobe is a primary motor cortex, and then dia ada macam like a very specific function, contoh macam personality. So kalau from history, macam dia punya family members complain that patient suddenly macam ada change of behaviour, change of personality. Macam previously dia macam ni, tiba dia macam personality dia like change totally. So that might indicate macam ada something happen at the frontal lobe juga. And then kalau like patient ada aphasia, like we know kan that ada 2 types of aphasia, the Broca, the receptive and the receptive dengan expressive Broca kan. So kalau patient ada expressive Broca, so that is macam suggest yang patient ada something happens at the Broca area lah, so patient express kan, macam tu jugalah. So things like that lah yang macam boleh suggest. Macam internal capsule ke midbrain. Kalau internal capsule ni usually the lacuna stroke lah, patient have a very macam macam mana, dia ada weakness tapi dia macam sometimes only the upper limb ke, only the lower limb saja ke, dia macam tak menyeluruh macam tu. Menjawab tak? Okay. Ada lagi ke question before we stop?
So I think there will be no more question. So thank you for Sister Amni and Dr. Hajar for a very informative sharing. So I would like to remind the participants to fill in the Google form for the start point via the link provided